It's been a great privilege and honor to attend and present my lecture titled Innovative Surgical Techniques and Two-Stage Transplantation in the Liver Transplant Updates 2024 in Cell. Unfortunately, I cannot present personally, but I would like to thank the organization committee for this kind invitation. There's a severe global organ shortage. If you look at the WHO numbers, less than 10% of global organ transplantation need is met across the world. This implies a significant lack of number of transplants that is performed throughout the world, and one of the growing concepts in our field of liver transplantation is liver transplant oncology, which will further increase the demand for liver grafts. There can be one answer for this, that is rapid procedure, would be in both cirrhotic and non-cirrhotic settings. The rapid procedure is a novel concept that implies that's been first performed in non-resectable colorectal liver metastasis setting, and inspired by ALPS procedure and deceased donor split liver transplantation. Rapid procedure has been performed in the non-cirrhotic setting initially, and there has been historically, there has been a stepwise evolution of the early series of APOD procedure by Professor Bismuth, which was applied in the fulminant liver failure settings, and then first two-stage procedures, APOD procedures in 1999 in Japan, and 2015 rapid procedure in colorectal cancer liver metastasis setting, and normal livers, no portal hypertension, and the rapid procedure in portal hypertension and cirrhosis has been performed by us later on. The main difference between the rapid procedure as a two-stage transplantation setting than the APOD procedure is the systematic short delay between two operations, native liver deportalization, and portal inflow modulation. These describe the differences of rapid procedure than APOD procedure. And the indications are also different. APOD procedure is indicated in metabolic disease and fulminant liver failure, while rapid procedure can be applied in no portal hypertension setting as well as portal hypertension setting. In cirrhosis can be applied both metastatic liver cancers and primary liver cancers. If you look at the European experiences in colorectal liver metastasis settings, there has been a paper published by 5 centers in Europe, and they performed this in colorectal liver metastasis setting. This paper, they have been shown that graft hypertrophy between the two stages has been successfully achieved, and the procedure can be performed successfully in selected patients. And this initial experience of deceased donor liver transplantation has been applied to living donor liver transplantation setting by a German group. So this is performed in both deceased donor and living donor transplantation settings. And in living donor liver transplantation, graft is by definition a small for size graft, and immediate graft regeneration and avoidance of sinusoidal injury is critically important in portal hypertension patients with cirrhosis. And after the implantation, the size is not modifiable, only the inflow is modifiable. In our understanding, in a partial graft is heavily relies on the graft size and quality to meet the metabolic demand of the patient. However, both inflow and outflow should be functioning perfectly. In the non-portal hypertension setting, depicted in the left side, we see the sufficient arterial flow, less portal flow, and good outflow. A small size graft will function sufficiently, but in the cirrhotic setting with portal hypertension, portal flow increases significantly and arterial flow decreases according to hepatic artery buffer response. So this needs to be controlled in the cirrhotic portal hypertension setting. We could describe this as a difficult marriage of ALPS procedure and partial liver transplantation. This is one of our early cases of picture. You can see the cirrhotic liver next to the non-cirrhotic graft. Our first case has been performed in 2019, and this patient has completed 5 years follow-up recently without recurrence and normal AFP. So this was a 3 centimeter HCC in the right lobe, and this patient is still healthy. We've shown this it is feasible in the non-cirrhotic setting. In cirrhotic setting, in low MELD score patients with HCC and low portal hypertension patients. However, a different clinical scenario could be for a high MELD score patient with portal vein thrombosis. I would like to show a small video clip about this that is showing Wilson's disease patients with portal vein thrombosis, a young patient, 82 kilograms, MELD score 27, hepatic encephalopathy 3 times, and the only donor available has 26% left lobe, so the only possibility is left lobe donation. This is from the operation. This is a significant coronary shunt that diverts the portal blood flow, causing hepatic encephalopathy. We measure the flow is about 1 liter per minute portal flow, and this is the thrombosed atretic portal vein. There's a reverse portal flow. This is the initial dissection of the hepatic inflow and outflow. We complete the resection of the cirrhotic liver. It's a left lateral sectionectomy and division of the left bile duct as seen here. And this is the left lobe graft. The GRWR is 0.45 with 368 grams of liver. Here we see we reconstruct an interposition jump graft. And here, after hepatic vein anastomosis, we reconstruct the jump graft to the coronary varix as an inflow. When it is open, the liver flushes nicely and we measure the flow. The flow is about 220 milliliter per minute, and with the shunt open, and then when the shunt closes, it goes up to 300. So we leave the shunt open as a inflow modulation. Portal pressure is 40 millimeter mercury. Is the bile duct. At the end of the procedure, when the shunt closed, portal flow is high. This is after the first stage. Bilirubin and the function, they recover nicely. Postoperative day 13, there's significant liver regeneration. GRWR becomes 1.1. Shunt still perfectly functions, and hepatobiliary scintigraphy shows the functional shift. And this is from second stage, and this liver is out. This patient has been discharged in an interval period and then come for second stage operation. After the second stage operation, this is a 6-month scan. This patient is now 3.5 years follow-up without any problems. So we have 10 cases so far. 5 cases in Ankara University and 5 cases in Istanbul Balci University. The GRWR range is 0.336 to 0.51. We have lost 3 patients. And for the recipient, rapid procedure and 2-stage procedure, graft volume is not important. GRWR potentially can become obsolete. Small pore size syndrome may become history when the procedure is safer. And the anatomy in almost all of the cases is not a limitation because of left lobe donation. This is still an experimental and high-risk procedure. And if you look at the literature review, published series, there's only limited cases, around 34 cases with almost 30% 90-day mortality rate. So the procedure still is in the development phase. Now we can say that after the early experience in Japan, we are growing new experiences of rapid procedure and two-stage transplantation procedures. However, it may change the way we do liver transplantation because it decreases the donor risk significantly using the small left lobe volume. We can hopefully shift to left lateral section in the future, potential increase in donor pool in both deceased donor and living donor liver transplantation settings. And with the growing transplant oncology concept, the patients can have timely transplantation as a curative option for not only primary liver cancers, but also secondary liver malignancies. Yes, it can be high risk in the early development period, but I would like to show this historical paper of ALPS procedure coming almost 12 years ago, reported in the early phase. It was heavily criticized because of high-risk procedure. However, it became a standard procedure. I think one-stage transplantation versus two-stage transplantation is in the similar development phase right now. But ALPS procedure in 2022, in 10 years, became a routine procedure in many centers. So two-stage transplantation could be as well. These are some of our cases in Istanbul. So this procedure, we had held a consensus conference in the International Society of Liver Surgeons 2023 meeting, which will be published soon. And there's study groups going on in the International Society of Liver Surgeons. You can join online to us. And I would like to invite all of my colleagues here to Toronto, which 6th International Society of Liver Surgeons Congress will be held in between October 22 to 25 of 2025. Thank you.